practice that will develop either acute pain or have chronic pain. And the importance here is to, oh, it's not advancing. Wait a minute. Okay. Maybe now it will. All right. What I would like to be able to discuss is to define the problem, to really talk about how MAT patients are maybe a little bit different on one hand and very similar on the other hand to non-addicted chronic pain patients. Also, I think it's important to define what acute and chronic pain is and how specifically to treat them in the MAT patient, and to talk a little bit about surgery. And lastly, I wanted to just touch on the role of naltrexone in pain management. Nope, it's not letting me advance, so okay. Good. Okay. In 2004, my addictionologist called me and asked me to obtain my waiver so that I would be able to accept patients from him who he was unable to wean due to the fact that they had significant chronic pain. And that was back in 2004 when we were supposed to only keep patients on Suboxone for anywhere from 6 months to at most a year. And of course, nobody had more than a 30 patient limit. So it was important for the addictionologist to be able to stabilize patients and refer them on. And so he wanted to refer those patients to me. I agreed. I started getting all of these patients. The problem was I didn't know what to do with them, because there was really nothing in the literature that really gave us any idea of how to handle an MAT patient who had chronic pain. So I just started basically, flying by the seat of my pants and tried figuring things out. To talk a little bit more about what the problem is, there are, according to the CDC, about 50 million people in the US who have chronic pain. 20.4% of the population in the US is chronic pain. And then when you add that to the fact that in the 80s and 90s, the golden era of pain management, by the way, I mean, that was the time to be, a doctor and wanting to treat pain. Didn't matter whether you knew anything about it, you could do it. Pain was the sixth vital sign. Some people say fifth, but it's sixth if you add pulse oximetry. Anyway, it was a vital sign. Joint Commission said everybody has to be evaluated for chronic pain. Everybody has to be rated and of course treated. And then the best thing was that the cure for chronic pain came out, and that was OxyContin. OxyContin was a long-acting drug, which of course is what pain management specialists wanted, and it was also non-addicting. So that's a wonderful, wonderful drug. And anybody basically with a DEA number could prescribe OxyContin, and that's what happened. We got an awful lot of people in the 80s and 90s who became addicted to pain medication because it was way overprescribed. And unfortunately, these people are showing up in our offices. If you look at the misuse rate of patients who are prescribed opiates who have chronic non-cancer pain, depending on the study, the range is anywhere from 21 to 29%, with an addiction rate of 8 to 14%. So, or 8 to 12%. That's quite high. And then there was another study that my fellow pain management colleagues liked, and this was a study that was done at the University of Miami, and it was published in Pain Medicine, where they actually reviewed 67 studies of patients who were placed on opiates, and they followed them long enough to be able to determine who got into trouble. And what they found was in the majority of studies, 43 of them to be exact, the addiction rate was about 3.5 3.27%. But in 24 of the studies, the physicians participating in the study actually pre-screened the patients before they put them on opiates. They pre-screened them for addiction history, for family history of addiction, any other things that they were concerned about, and they didn't prescribe opiates. And in these 24 studies, the actual addiction rate was only 0.19% versus 3.27%. Same thing with the aberrant behavior. Aberrant behavior overall in the 67 studies was 11.5%, but in the 24 studies that's pre-screened, it dropped down to 0.51%. So again, this is great evidence for before anybody goes on any kind of pain medication, they need to be screened. It's the obligation of the physician writing the prescription to make sure that they get a history. And then lastly, as you can see there, there's not enough of us to take care of this problem. If we were even going to handle the chronic pain that may have been the starting point for addiction in some of the patients, we couldn't handle them. 75% of the 102,000 physicians who do prescribe only have 30 patient waivers, and many of them don't prescribe. So it is potentially a problem. In a VA study, 52% of opiate-dependent veterans who were seeking MAT complained of chronic non-cancer pain. This is quite significant. Opiate addiction will also cause decreased tolerance and increased sensitivity to pain. And this has been borne out by a lot of different studies, like sibling studies where one sibling has an addiction problem, the other one doesn't. MAT patients compared to matched controls. C-section patients where they looked at how much pain medication was given post-operatively in patients who were on, say, methadone MAT versus controls, and found that 70% more pain medication was required in this particular group of people because of increased pain sensitivity. MAT drugs, buprenorphine primarily, which is what we're going to be talking about in this today, but also methadone, they both are long-acting drugs. That's great. That's great for MAT, but it's not great for pain because the analgesia that you get from these drugs doesn't go beyond 6 to 8 hours, which means there has to be divided doses. You can't give once daily dosing for methadone, once daily dosing for buprenorphine, and expect the patient to be pain-free for 24 hours. It's not going to happen. Shorter acting opiates are less than ideal in chronic non-cancer pain. And the reason for this, the reason why pain management doctors do not like short-acting drugs is because you get this peak trough every time they take the medication. 2-3 hours later, it goes down, and then it goes back up. And this constant up and down, up and down, up and down of blood levels is known to hasten opiate tolerance and decrease efficacy of the opiates for pain relief. So we want to try to avoid that whenever we can. Patients physically dependent on any pain medication will require the exact same amount of pain medication in addition to what they're normally taking compared to a or an opiate naive patient who experiences the same type of pain stimuli. So the attitude that some physicians take that, oh, well, the patient's already taking 16 milligrams of buprenorphine, so he doesn't need anything additionally. No, that's not true. The 16 milligrams is a baseline. Then if they do need something, then you have to go up from there. And that difference is the same whether a patient is on pain medication as a baseline, constantly on it or not, like for MAT. And MAT patients do exhibit cross tolerance to other opiates. we are going to be talking about giving opiates to patients who are on MAT. It is done. There are some significant concerns about it, and we're going to try to address that. Oh, I think I'm going the wrong way. So the next thing I want to do is I want to focus a little bit on what acute pain is. And acute pain is really more a pretty simplistic thing. Acute pain is just pain that is the direct result of an injury, usually a soft tissue injury that lasts less than 3 to 6 months. And it resolves, the pain resolves when the injury is healed. MAT patients are no different than anybody else. They get acute pain. They can have injuries. They can have accidents. They can have surgery. Treatment of acute pain is simply diagnose the underlying problem, treat the problem, the pain goes away. You don't have to do anything else. But when you talk about MAT patients, what happens? So if I have a patient, say I've been seeing a patient for maybe 6 months or a year in my office, and they come in and I sit down with them and say, hey, how you doing? Oh, doc, I am in misery. I pulled my back 2 weeks ago helping my brother move furniture, and I haven't been able to sleep since. I am just in excruciating pain. Okay, so the first thing that I do in a situation like this is make sure I got a drug screen that day, because I want to make sure that the patient isn't treating himself with other illicit drugs. And then we need to talk a little bit about what do you do at this point. Some of my patients, they regard me as their doctor. They don't go to other doctors, so they may not have had an entry into the medical care for their acute pain until they've come to see me for their regular MAT follow-up. So what I would do in that situation is initiate treatment with a non-opiate medications such as acetaminophen, NSAIDs. If they have muscle spasms, give muscle relaxants if they're needed. Talk about what is important with regard to acute pain. They need to understand that the focus of the endpoint of treatment is not how good of a pain medication they're getting, but how good the treatment for the underlying problem is. So they have to be able to understand that if they're having such severe pain that they can't consider going to physical therapy, or if they've been prescribed physical therapy, they can't participate in it appropriately, then yes, that's a time then that you have to maybe give some additional buprenorphine or something for their pain. But that's not the end all. The end all is that's to allow you to go to physical therapy. That's to allow the muscles to heal, which is what's causing your pain. So they must understand this. And they also, it's crucially important for patients to understand that what the goal of the treatment is, and how that's going to be accomplished, what the plan is, where medication fits in, et cetera. So these are things that any MAT physician can talk about if you have a patient with acute pain. That is something that you can deal with. Oh, keep going the wrong way. So if the pain is significant, and by significant, I mean pain that is precluding proper treatment of the underlying condition, okay? Not because they hurt, but because the pain is preventing appropriate treatment. The pain is interfering with their life. They can't work because they have pain, something of that nature. Then I might seriously consider dividing their maintenance MAT into 3 doses, and to increase if necessary. Usually dividing it into 3 doses, giving NSAIDs, ice, elevation, those kinds of things, considering physical therapy, whatever else, or whatever is going on with the patient when they come in. that should be sufficient. But if it's not, what I usually do is I try to see them back in 2 weeks rather than 4 weeks, because then if I need to do something, I have the ability to do that. Another thing that's very, very important in MAT patients with acute pain is you gotta emphasize to them that they still need to do their recovery work. It's crucially important for them to do that. If they don't, it doesn't make any difference whether the pain is better and the patient's relapsed. There are often comorbid psych disorders like depression, stress, anxiety, sleeplessness, etc. These are usually not real serious if it's the result of acute pain because they haven't been going on very long, and these things should be addressed and taken care of. Okay, let's see. Okay, so the next thing I want to talk about is buprenorphine as an analgesic. The only buprenorphine that's allowed in the United States is either parenteral or transdermal formulations that are approved for pain. They are not approved for addiction according to the Drug Addiction Treatment Act of 2000. On the other hand, if you look at the sublingual, subbuccal formulations, they are only approved for addiction, and of course, the physician has to have a waiver in order to be able to prescribe for addiction. However, the most important thing to emphasize here is that any physician with a legitimate DEA number and is capable of writing Schedule III drugs is capable of writing buprenorphine for pain. It is entirely legal. I've been doing it for years. You have to write for pain on the script, and now with the new laws, you would also have to write the underlying diagnosis code for whatever is causing the pain for the acute pain. So you have to have a pain-related ICD-10 code also on the script. And the prescription is fine. It's not a problem. I've been doing this for years, as I say. I've never had a pharmacist question it. The problem that I have is trying to get these patients to go back to their primary doctor if they need to continue the buprenorphine, if these are patients who are now in a chronic situation, okay? The primary care physicians are afraid to take the patients and write Suboxone because they're not waivered, and they don't want to write for pain. They're afraid they're going to get in trouble. So those are kind of separate issues. Oh, keep going the wrong way. Okay, so let's talk about chronic pain. Let's first talk about what it isn't. Chronic pain is not acute pain that lasts longer than 3 to 6 months. Not at all. Chronic pain, I define as pain that lasts longer than 6 months that takes on a life of its own. Pure and simple. Chronic pain no longer has a direct cause and won't necessarily respond to conventional treatment of the original injury. Chronic pain pathways become hyperactive and self-perpetuating. That's the central sensitization that you may have heard about. That's pain that is basically in the brain. Over time, pain becomes more intense. It becomes more widespread. Pain is often, the patient with chronic pain often sees a decrease in pain tolerance and an increase in pain sensitivity, which of course then requires more treatment rather than less treatment. Often the secondary problems that result as a result of chronic pain, like stress, anxiety, fatigue, sleep disorders, depression, these things become much, much more important than they would have been with acute pain. And appropriate treatment of chronic pain has to include these issues. And that brings us to the last point on the page. Because of all of these other issues, because of that, a team approach is the way to go. So the person that runs the team that coordinates all of these specialists, decides who sees patient when, and makes sure that there isn't contradictory treatment. That's all coordinated by the pain management physician. So he's able to see the forest for the trees. All the specialists are just looking at the individual trees, so to speak. But nonetheless, that is what a pain doctor actually does. He's really just a coordinator. Now it's not advancing at all. Let's see. Oh, there we go. Okay, so the next question is, what is the goal of pain management? And again, it's pain management, not pain relief. The goal of pain management is a 50% reduction in pain with a concurrent increase in meaningful activities, socialization, employment, improved ADLs, increased strength, etc. The goal of pain management is to overcome the secondary problems that we've talked about, the depression, anxiety, sleeplessness, etc. Decrease the patient's reliance on medications in the healthcare system, to try to get the patient to realize that, he's a person. He's not a pain person. He is a person who has pain. Let him focus his life not around the pain, but around the other things. And part of that is getting away from medication, getting away from the healthcare system. And the last thing is the most important thing. Again, we need to make sure that the patients understand that they are the treatment. They are the solution for their pain, not the doctor, not the pill, not a shot, or a blood, a pain block. Okay, that is not the important thing. They play the central pivotal role, and it's up to us to deal with this and to get them to understand it. And again, motivational interviewing, I find, is very, very effective at doing this. Let's see. Okay. So when we're talking about buprenorphine's role in pain management, especially chronic pain management, I can't emphasize this enough. The first thing we do is we treat the addiction. Okay, I get a tremendous number of patients, as you might suspect, that patients who come to me because they have gotten in trouble with addiction, and their introduction to pain medication was a legal prescription for a pain problem. So a lot of patients, when they come in with this, yes, they may acknowledge their addiction, but they're focused to some degree on their pain problem. And it's important, in my opinion, to change that focus and focus it on addiction. It's addiction first. Pain is a distant second at that point. So basically what I do is I basically tell the patients that if they go and do the things that we're talking about, get the counseling, go to 12-step meetings if that's what the way they're going to go, work a program, you have a sponsor, do all the things they're going to do so that they start developing better relationships with other people. They start developing relationships with themselves that's based on trusting oneself, liking oneself, and respecting oneself. Those changes in one's personality and one's being will help decrease some of that pain. And so chronic pain may not be as significant a factor as it is now if they treat their addiction. Only at that point do I really get into pain management with these patients. And that can take anywhere from 9 months to a year before we really start looking at if there's any other diagnostic tests that need to be done, if there's anything else that needs to be looked at, or any records that we still don't have that we need to get. Then and only then do I start looking at pain management along with addiction. Now, it is possible in both acute and chronic pain to stop buprenorphine and replace it with an opiate. I don't do this. I don't believe in it, okay? And I don't supplement buprenorphine with a pure agonist for additional relief. The only exception I make to that is post-surgical pain, and there is a situation where there is indication, and we will talk about that in a couple of minutes. So what do I do? Well, if, again, the patient is uncomfortable, this can occur early on. Instead of a single dose dosing of buprenorphine, I will consider multiple doses, okay? So 2 or 3 doses a day. And the doses aren't necessarily equal either. If a patient tells me that they have most of their pain on the days they go to work, then what I will tell them to do is take maybe half of their maintenance buprenorphine right before work, and then take the rest of it after work in 2 divided doses. That oftentimes will work. If sleep is a major problem, then I will give them more buprenorphine at night before they go to bed versus their doses during the day. And this is where one also can consider anti-inflammatories, the tricyclic antidepressants, the other antidepressants, the SSRIs and SNRIs, the anticonvulsants. All of these medications need to be used before I start increasing the buprenorphine significantly. I do not do that. My goal is to use the buprenorphine for addiction and supplement with all of these other medications, other modalities. Maybe physical therapy was tried before, but it wasn't appropriate physical therapy. It was all passive modalities, for example. So I might then go back to physical therapy or try something else like aquatherapy. Psychological counseling is crucial. If you can find a good psychologist who's willing to take these patients on, biofeedback, relaxation therapy, self-hypnosis, there's all sorts of things that can help patients who have chronic pain. And if all else fails, that's where supplemental doses of buprenorphine come in. Bottom line, there just simply is no real rule of what to do. Well, once again, there we go. Okay, so let's talk a little bit about elective surgery in MAT patients. There are a variety of options. The initial thing that we were doing back in the early 2000s was we were telling all the patients if they knew that they were going to have surgery, they should immediately stop their buprenorphine 5 days, 3 to 5 days, preferably 5 days before the surgery, and resume it post-operatively once they were to the point where they wouldn't need any other kind of medications and they could go back to their buprenorphine. That's not as popular today, and the reason, and this has happened to me, is if you stop a patient 5 days before their surgery, don't be surprised if on day 3 or day 4 they relapse and they never show up for their surgery. So I tend not to do that. What I tend to do is I will continue their buprenorphine up to the day of surgery. I don't give it the day of surgery. And then depending on the surgery that they're having, I will give them other instructions. For example, for minimally invasive surgery, dental surgery, for example, little lumps and bump type surgery, that kind of thing. NSAIDs, ice elevation, acetaminophen, these things will handle the pain. You don't need to really do anything. They can then the next day take their normal dose of buprenorphine and they're just on their way. They shouldn't have much of a problem. On the other hand, for patients that have a more significant procedure where they could have some pain, extensive laparoscopic procedures, some of the simpler orthopedic procedures, open reduction, internal fixation type of things, they're going to require some medication. So what I usually do in those situations is I will increase their buprenorphine for about 5 days. And I do that for anywhere from 4 to 8 milligrams a day additionally beyond what they're taking. And again, the majority of my patients are taking between 8 and probably between 8 and 16 milligrams. I have very, very few patients who are receiving maintenance doses of buprenorphine greater than 16 milligrams a day. So I cap it at 24 in situations like this. And again, giving these medications in 2 to 3 divided doses. Now, for the extremely painful procedures, the hip and knee replacements, thoracotomies, upper abdominal incisions, things where these patients are going to be hospitalized postoperatively, this is where we get into using agonist opiates, okay? This is where Percocets, IV medications in a patient-controlled analgesia setting, a PCA, this is where this comes in, and it does work very effectively. They don't take their buprenorphine postoperatively. They are on pain medication, and after 2 or 3 days, I'm usually comfortable with them going home on, say, Percocet or something of that nature, some form of oxycodone or hydrocodone. They go home with that, and they'll be on that for another couple of days. At that point, I tell them, stop taking that medication, wait until their pain becomes very significant or they start developing symptoms of withdrawal, and then to go back and restart their MAT medication in the dose that they were taking before, and then supplement that with NSAIDs and all the other things that can be used. So one of the things that I used to have to do all the time was send notes to doctors, let them know what to do, even instruct anesthesiologists. I mean, there was anesthesiologists back in the early 2000s didn't know what Suboxone was, much less how it would affect anesthesia. So there was a lot of educating. Today, I don't do that as much, but one of the things I do is I will offer to the surgeon to take over their post-discharge pain if that is desirable. And a lot of surgeons allow me to do that. And that way, I know exactly what they're getting. I can control the amount of Suboxone they're getting and determine when I need to see them again in order to deal with pain, rather than have the surgeon do it, because the surgeon's not going to be able to do it with the Suboxone, whereas I can. The other thing that I do caution patients about is not to fill prescriptions, especially for the milder procedures. Don't fill prescriptions of opiates, because then the ORS is all messed up, and you get calls from the pharmacist, and and the insurance companies then, I've had insurance companies contact me and said, we are no longer going to pay for your patient's buprenorphine because this patient has gotten a prescription for oxycodone. Well, yeah, they got a prescription for oxycodone for 4 days for their postoperative course. I mean, but it's just a lot of extra hassle, which I don't like to deal with. So for minimally to moderately invasive procedures, buprenorphine doesn't need to be stopped. I stop it on the day of surgery only, then restart it using a combination of NSAIDs, ice, elevation, etc. For the more significant pain, this is where regional anesthesia comes in, doing post-op pain blocks, such as, and I've got a bunch of them listed there for the various types of major surgeries. These are, and most anesthesiologists today know all about this. They know how to do this. It's not a problem, and things go pretty well. There are, as I've implied in the past, in the last few minutes, there is the potential role of buprenorphine in chronic non-cancer patients who are not addicted. They come in because they know that they have a family history of addiction, or there may have been a remote problem that they themselves experienced, and they need pain medication, and their doctors are trying to give them pain medication, and they know better than taking it, and they come in to see me. And one study that I quote here is a study of 95 patients who were switched from opiates to buprenorphine. The mean dose of buprenorphine for their pain was only 8 milligrams a day. 86% of these patients had moderate to substantial pain relief with increased mood and functioning. Only 6% failed. So I do have pain patients who take buprenorphine. They are not going to meetings, they are not addicted, and they do quite well. As with any patient, it's very, very important that we understand what the goals that the patient is striving for, to correct misconceptions. I use a lot of motivational interviewing for all of this in order to be able to get the patient to take on the central role of taking care of themselves and being responsible for their own pain rather than have me responsible for it, and to get them to understand what a reasonable result is and how to achieve that. I just want to spend just a couple seconds on naltrexone. Naltrexone can play a role in neurobiologically or physiologically based chronic pain. In other words, pain that is more central. Migraine headaches, fibromyalgia, PTSD-related pain, central sensitization type pain. And the way that does that is because in chronic pain that is neurobiologically and physiologically based, there isn't a normal elevation in endogenous opiates, and treating with naltrexone will drop those levels, and it does help. It isn't effective with tissue damage pain, so any type of pain due to arthritis, degenerative joint disease, disc disease, peripheral neuropathies, ischemic pain, endometriosis, adhesion pain, this kind of stuff, naltrexone doesn't work. And lastly, naltrexone is a big problem for surgery, and it remains a big problem for surgery. That's one of the reasons that I don't like to use it. Oral naltrexone, the way it's most commonly given is about 150 milligrams every 3 days. You take about 50 milligrams a day on average. And this isn't as much of a problem because if it stops 72 hours before surgery, the patients are doing okay. Vivitrol, on the other hand, has got to be stopped a month before surgery. If it can't be because there's emergency surgery, the naltrexone blockade can be overwhelmed, and anesthesiologists can do it, but we're talking 6 to 20 times the usual dose of opiates. This is potentially dangerous, and the patients have to be hospitalized. They have to be monitored extremely closely postoperatively. And of course, postoperative pain relief is going to be along the same lines, that they're going to have very significant increase in the amount of pain medication that they would require. So these are some of the references that that I used to develop the topic, and I think Kay will post all this so you'll have it. And lastly, I thank everyone for listening and not falling asleep, but also I wanted to give special thanks to Kay. She has a wonderful ability to do PowerPoint that I lack, and she turned a very bland, hard to read PowerPoint into the presentation that you saw. And so, Kay, thank you very much. And that's it.